Morning, folks, and it's wonderful to have you um, join us this morning, taking time out of your very busy schedule for the Sickle Cell Awareness Group of Ontario and Ontario Health Town Hall with the Sickle Cell community. Thank you so much for being here. Our goal today is to create a space for open dialogue on the implementation of the quality standards for sickle cell disease. We wanted to hear from folks and also to present to folks how the implementation is progressing and hear your opinion and your feedback. We wanted to know, have you seen improvements in the quality of care that you receive within the Ontario healthcare system? We are also going to use today's opportunity to also share with you the Ontario Health provincial model of care, as well as the patient experience reporting portal by the Sickle Cell Awareness Group of Ontario. I'm going to encourage you to hang tight as we are eager to present and also to hear from you and to help us, with your feedback in ensuring that we continue to make informed decisions that benefit every individual that is affected by sickle cell disease in the province of Ontario. Again, there are some housekeeping rules. So we ask you to kindly keep yourself muted, right? You can always put your questions, your comments in the chat until there is opportunity for open discussion. At that point, you can use the raise hand feature for you to speak, and we will call you to provide your comments at that time. There will also be a break time, right? So whereby we can all stretch and we can rejoin again. So on this note, I want to thank you again, and I want to welcome you to the Sickle Cell Disease Town Hall meeting, co-hosted by Ontario Health and the Sickle Cell Awareness Group of Ontario. Welcome. Next slide. Next slide. We're grateful for the opportunity to gather, though virtually, on this land, and we thank the generations of Indigenous people who have taken care of this land long before other nation groups came. In particular, we acknowledge that the land now known as Ontario is a traditional territory of many Indigenous nations, including the Anishinaabe, Haudenosaunee, Huron-Wendat, Métis, Cree, Algonquin, Mississaugas, Lenape, and Inuit peoples. This land is covered by numerous treaties and agreements, including the Dish with One Spoon, Wampum Belt Covenant, the Upper Canada Treaties, the Robinson Treaties, the Williams Treaties, and Treaty 9, among others. We also recognize the contributions the Métis, Inuit, First Nations, and other Indigenous peoples have made in shaping and strengthening this province and this country as a whole. We reaffirm our responsibility to uphold the spirit and intent of treaty traditionship in working to advance equity in healthcare across Ontario. We are also encouraging everyone onto this town hall to continuously educate ourselves about the colonial history of this country and understand how the wrongdoing of the past still impacts the present and the future. Thank you. And next slide. Thank you. Our speakers today, I'll be happy to introduce them. We have Dr. Jennifer Bryan. Dr. Jennifer Bryan is emergency physician with the University Health Network. She's an associate professor, Division of Emergency Medicine, University of Toronto. She is the clinical lead for sickle cell disease and for the Clinical and Quality Standards Ontario. I also want to mention that Dr. Jennifer Bryan has led the sickle cell disease working group for the emergency department at the UHA for many years now. We also have Ms. Carol Kennedy, who is the lead clinical and quality standards Ontario. And we have Ms. Fitzy Ann Arwell, who is a person living with sickle cell disease. She's also the chair of the Sickle Cell Awareness Group of Ontario Patient Advisory and Advocacy Council. I can tell you that Ms. Howell is a passionate lived experience advocate for sickle cell disease, and she has used the many struggles that she has gone through personally, transforming those struggles into powerful platform for change in order to amplify the voices of others speaking out against health inequalities. Our unwavering commitment, I will tell you, to advocacy reflects both her resilience and deep compassion for underserved communities. Our next speaker is Ms. Mary Oduwale. She's a parent of a child with sickle cell disease, and she's also the co-deputy chair of the SCAGO's Patient Advisory and Advocacy Council. Ms. Oduwale is an active advocate, and I can tell you, and has helped to move a lot of changes within the sickle cell space. And we are very pleased to have her be part of the panel today. Without taking much more time, we'll go on the next slide, and I will hand over to Carol. Thank you.
Thanks so much, Lorraine, for the warm welcome, and thank you so much for having us back. I think we've been yearly to your town halls to share updates. This slide shows an agenda for today. We're going to do an overview of the Sickle Cell Disease Quality Standard and Implementation Approach. Mary and Fitzanne will be sharing some lived experience stories, and then we'll have some time for question and answers. After a short break, then Dr. Jennifer Bryan will share some updates on the provincial model of care. And under her leadership, we've been making great progress with this work. And then we'll wrap up with a discussion. Next slide. So the objectives for today, as I mentioned, are to provide an update of the implementation approach and where we are now with the Sickle Cell Disease Quality Standard work, to learn about implementation of the quality standard from the lived experiences of people with sickle cell disease and their care partners, and finally to share progress on development of the provincial model of care for sickle cell disease. So next slide, please. We'll provide a brief overview of the quality standards program. Next slide. And for those of you that might not be familiar with the quality standards program, just a little bit of background. This program is part of Ontario Health's legislated mandate to manage health service needs across Ontario, consistent with the ministry's health system strategies, to ensure the quality and sustainability of the Ontario health system through the clinical and quality standards developed for patient care and for safety. The quality standards focus on conditions or processes where there are large variations in how care is delivered, or where there are gaps between the care provided in Ontario and the care patients should receive. They focus on areas for clinical improvement with measurement indicators. And to date, our program has 40 published quality standards that are updated every 5 years. Next slide, please. Ontario Health Sickle Cell Disease Quality Standard was released in January 2023 and is a key deliverable under the province's Black Health Plan for Ontario. The Black Health Plan was developed jointly by Ontario Health, the Wellesley Institute, and the Black Health Alliance, led by community and healthcare leaders in response to long-standing systemic health inequities experienced by Black populations. The plan urges healthcare providers, organizations, and governing bodies to take action on recommendations it has set out. The goal is to ensure that Black communities across Ontario receive safe and equitable care and improved outcomes. And just to mention, Dr. Brian will be adding links to where we have QR codes in the deck, so you can take a look at some of the resources we're sharing through the chat. So the next slide shows when we release a quality standard, there are a number of resources that come with the quality standard. So we have a patient guide that's targeted to patients and care partners and families. We have a placemat that's targeted to clinicians, and it's meant to be a tool that can be embedded within electronic medical records, and it's sort of a quick reference for clinicians to use in their daily practice. We have a generic getting started guide that is for organizations or individuals that want to do quality improvement work in their own healthcare setting, and it just helps them, shows them how, using quality improvement methods, how to get started to implement the quality standards. We've developed an implementation toolkit to support the implementation of the quality standard, and a measurement guide that includes more details around the indicators that are included within the quality standard. Next slide. The patient guide is designed to give patients information about what quality care looks like for various conditions. So the patient guide that we're sharing here is specific to sickle cell disease, and it's based on the best evidence so that patients and care partners can ask informed questions of their healthcare providers. Next slide. The sickle cell disease quality standard includes 8 quality statements, beginning with a statement on racism and anti-Black racism. They provide a framework for delivering high quality care. And this quality standard addresses care for children, young people, and adults with sickle cell disease. The scope of the quality standard includes screening for and prevention of complications, the assessment and management of acute and chronic complications, and the use of disease-modifying therapies. And it applies to all pediatric and healthcare settings. The quality standard was developed with an advisory committee, including people with lived experience, community advocates, clinicians, administrators. We had executive directors from community health centers, part of our advisory committee. I see a number of the members of our advisory committee here today, so wonderful to see your faces again, and for the great work that you did to develop the quality standard with us. So today we're going to share the approach to support implementation of the quality standard. So we can go to the next slide and the next slide. In 2022 and 23, we'll go back one our team conducted public consultations, receiving input from partner organizations, lived experience advocates, and quality standard advisory committee members in order to better understand barriers and enablers of high quality care and to create an implementation plan. Next slide, please. To support the implementation efforts, we have been very fortunate to have several streams of funding initiatives that have been supported through fiscal years, the 23, 24, and now into 24 and 25, to provide a data-driven and strategic allocation of financial resources to drive implementation of this quality standard. I'll mention briefly the dedicated funding streams. There's base funding provided to adult populations and pediatric populations within the dedicated centers, the sickle cell disease dedicated centers. And this funding stream aimed to enhance the quality of care provided, alleviate pressures on established dedicated centers, and funding to newly funded dedicated centers. In addition, within this funding stream, SCAGO received funding for the Patient Wellbeing Program in Southwestern region to provide psychosocial supports to that region through this program. The next stream of funding was pediatric recovery, and this base funding is part of a broader investment by the Ontario Ministry of Health to specific implementation of the quality standard in pediatric settings. And then finally, we had a stream of funding directly to the sickle cell disease quality standard implementation. This was one-time funding that was aimed at supporting quality standard implementation and recruiting a clinical lead for sickle cell disease. And this is Dr. Jennifer Bryan, who has been an incredible leader and support to our team in developing the provincial model of care and many other aspects of implementation of this quality standard. Next slide. So here's a summary of program implementation milestones to date. And as I speak to some of these, again, Jennifer will be sharing some links to some of the things I've mentioned. So we released the quality standard in 2023. Our data and analytics team have developed an e-report for tracking key performance indicators, and this is updated quarterly. We have a province-wide community of practice that is run through Ontario Health through our Quorum site, and people are welcome to join. We'll include a link there. There's been extensive education that has been done over the past several years. Sickle cell disease indicators have been included within quality improvement plan indicators. A number of hospitals have implemented evidence to practice tools where the quality standard is embedded within EMRs, within emergency departments and acute care. And I mentioned the funding streams, the 3 funding streams, and then a great deal of work around the provincial model of care, which Jennifer will be getting into more details a little later. So next slide, just a little more detail we're sharing here around the dedicated sickle cell disease center funding. These are the newly funded centers on the far right column, and then the established sickle cell disease centers in the middle column, which have received funding to support implementation and further development of the dedicated centers across all regions within Ontario. Next slide. I mentioned earlier the e-report. For anyone interested in seeing key performance indicators related to sickle cell disease across the province, the e-report is available through OneID, and we've been working with Lonray at SCAGO and SCAO and a number of other community partners in helping them to get access to the e-report. It includes a number of indicators, physician initial assessment time, triage acuity scoring, number of inpatient admissions, and emergency department return visits. And all the data within the e-report can be looked at a provincial level, at a regional level, or at a hospital level. And next slide, just to give you a snapshot, like a few indicators that we have been tracking through and to look at clinical impact. Through 976 healthcare team members have completed anti-Black racism training through just that one stream of funding, the quality standard implementation, that one-time funding. We were able to track that indicator. Through the SCAGO healthcare professional training, 891 Ontario users have completed one or more modules of the SCAGO training, and 189 have completed all 13 modules, which is incredible. And we've seen reduced median wait time to analgesia by up to 27 minutes. And that data we've been able to capture through the evidence to practice sites. And through the e-report, we've been able to identify 19% decrease in time to physician and initial assessment in the fiscal year 24 and 25. So next slide. We've recently, just this week in the last couple of days, we've recently released an impact assessment and infographic. We'll provide links to this. Overall, this impact assessment provides a comprehensive data-driven review of sickle cell disease quality standard implementation strategies to date, guiding ongoing quality improvement and sustainability efforts. So we hope you can take an opportunity to look through the impact assessment. And this work was led by Mafo, who's on our team and has been working on implementation supporting our team. So I'll pass it back to Laurie to introduce our lived experience stories.
Thank you. Thank you so much, Carol. And I'm sure folks, you might have questions for Carol. Just you can start to put your questions in the chat. Note them when we get to the discussion session. You will be able to also unmute and speak at that time. We're going to introduce again our lived experience individuals. So starting with Miss Fithian Howell. Miss Fithian, as I mentioned, has transformed her struggles into a powerful platform for change, using this to amplify the voices of others and speaking out against health inequalities. We would like to hear from Miss Fithian, her own experiences since the implementation of the quality standards, where you have received optimal care, and if this is not the case, we would like to hear from you in 10 minutes. So Ms. Fithian, you can take the podium. Thank you.
Thank you, Ms. Laurie. Thank you for having me this morning. I hope everyone's having a great morning. So as she said, my name is Fitz-Ann Howell. I am the chairperson of PACT. I've been a member of SCAGO for many, many years. I'm a lot older than I look. But since the quality standards have been implemented, I have seen an improvement. I will say that to start. I have been in the hospitals, as I said, I'm a lot older than I look. So I've been doing this hospital thing for a very long time. But not every interaction has been great. With the quality standards being implemented, a lot of us lived experience advocates, or a lot of us living with sickle cell, saw it as a turning point. It was a start. And because these quality standards are implemented, we did expect a change in how we're treated, in how we're operated with, in how we are approached just walking into the ED. Most of my experiences since implementing the standards have been optimal, have been great. I think it's also because, I do a lot of these talks and they may recognize my face. I don't know. I've been told that once. But there have been experiences where I like to tell the story of a ED doctor who came up to me, sat beside me on the stretcher in the hallway, and asked me, "What do I need? Teach me as if I've never heard of sickle cell before. What do I need? What do you want from me? What do you want me to do for you? What do you normally do?" And just taking that power dynamic out of it and coming down to my level shows that he used the quality standards. He read them, he understands them, he knows how to implement them. I've had experiences with nurses that usually nurses are terrified to fight for us and go up against these doctors, but nurses have been stepping up and speaking out, and no, they need this much at this time and it's mandatory, like they're in crisis. When we can't speak, it helps so much to have someone to speak for you. It does. But I've also had experiences if you were at the summit, you probably heard my story, but my last experience in the ED was actually in June, and I just was ticking off all the boxes in my head of how the quality standards were not being implemented. And it's very sad to say, because they've been in effect for a couple of years now. We've done enough education for it to at least be out there. Even if you don't know what it's about, you know it's out there and you have an idea of what it entails. If you don't, you ask questions and you work with your patient. You work forward from there. But my last experience was not any of those things. I never saw who the doctor was. To this day, I still don't know who that doctor was. Pain meds were not given. If you read the quality standards, it says within 30 minutes of triage and with 60 minutes of upon arrival. I was given pain meds within an hour and a half while sitting in a room crisising by myself. No family, because it was 4 o'clock in the morning. I was alone and I had to figure it out. I had to advocate for myself. And it was wonderful that I had nurses like I did, because they went to bat for me. They went to the doctor over and over and over again within that hour and a half span to make sure that those quality standards were implemented. When we do education, we put a lot of emphasis on quality standard for racism and anti-Black racism, and especially vaso-occlusive crisis, because those are the hardest things to break when it comes to these ED doctors, these nurses. Those are the two most important things when we walk into the ED. So to have experiences like that one, where I was basically treated like I wasn't a person, I was less than, because I came for help and I was bothering you, shows that there's so much more work that we need to do. There is so much more work that we need to do. We've done this much, we've come this far, and there have been so many experiences within the last year or so of me going to the hospital. I've had so many positive experiences, and I can say that's because of the quality standards. But there are still incidents like this one where you are discriminated against because of the color of your skin, because of your disease, because of something that you cannot control. You are treated less than. There are still people that focus on sickle cell being a one size fits all, and we deserve less than. So this is to show that we still have work to do. So the implementation of the quality standards, I've seen a difference. I've seen so much progress. I have seen so much growth in the hospital system, even in hospitals that are not my home hospital. But there is still those people out there that still need to be educated, that still need to be worked with, that still need that education, that still need to sit down and go through those standards and make sure that the care that they're giving is optimal care across the board. It doesn't matter if I have SS or SC or beta thalassemia. It doesn't matter what I have. I'm walking in for help. These are the standards. This is the blueprint you're supposed to follow. Please follow it. I would love to sit here and tell you all the positive stories, but we do have to sit and look at some of the negative stories to see where we need to make a change, to see how much work has been done and how much work still needs to be done.
Mhm.
And it's wonderful that we've come this far and there are less hospitals and doctors and nurses that are treating us the way they did prior to the quality standards. But there is still the 1 and 2 that are stuck in their ways, that see us as a burden or a problem or a bother. And with that, we still have to work. I don't want to take up too much more of your time. I don't know if I've hit my 10 minutes yet, but I like to always end with this. We do these things not for us, but for the babies that are coming after us. They can't speak. So to have the quality standards, to have them outlined in this way, in this manner, gives them a voice, even if they don't have a voice. It gives those that don't know how to advocate, that are scared to advocate, that are scared to step up, a voice. I'm not scared. I talk too much. That's my problem. But like the ones that are terrified, I get so many emails from patients telling me about doctors' experiences, and when they try to advocate for themselves, it reaps no benefit. So they stop. They shut down and they become quiet. They go home and they crisis in bed by themselves because they just couldn't take it. We do it for them. This is the blueprint to make sure that their care is the same as my care, is the same as Mary's kids' care that you're going to hear from in a second. This is why we have it. And we've done so much work, but there's still so much work to be done. And I want to thank you for your time. I don't want to take up any more of your time because I know there's so much more we have to get to, but I want to thank you for having me this morning. And yeah.
Thank you so much, Fitzian. That was amazing. Thank you for, for sharing. And I think this is one of the reasons why we are having this town hall to hear, your feedback and that will help us to determine what else can we do, right, to ensure that, it wouldn't be, based on who you see, everybody will follow the standard, right? And people will get quality care. Thank you so much. I would like to introduce next Miss Mary Oduwale. Miss Mary Oduwale, who is joining us today as the co-chair, along with Miss Vivian, co-chair of the Patient Advocacy and Advocacy Council of the SCAGO. Miss Mary Oduwale is committed to advancing health equity and ensuring that patient voices are heard. While she dreams of a cure for all those affected, she continues to advocate for care systems that are responsive to the daily realities of families managing this condition. And together, she believes we can strengthen the vital pillars that connect families, communities, providers, and policymakers. And this is why I think today is important to hear from Miss Mary, even though we know most of the time pediatric care has been said to be much, much more better than adult care. We would like to hear from Ms. Mary Oduwale if there are changes she has noted since the implementation of the quality standards and what she would like to share with us today. Ms. Mary, to the podium. Thank you.
Hi, everybody. Good morning. Thank you for giving me the opportunity to share my family's experience. Again, my name is Mary Oduwale, and I am the parent of actually 2 children. One of them lives with sickle cell disease. So our journey began 8 years ago when we received my daughter's diagnosis. And in that moment, our world shifted. We entered like a new reality of hospital visits, medical terminology, and a daily balancing act that actually continues to
I'm
this
sorry,
day.
Miss Mary, can you adjust your volume a little bit? It's a bit low, if you don't mind. Thank you.
Okay, is that a little bit better?
It's still low. Is there a way to increase it a bit? Thank you.
I am not clear on what I could do to improve it, other than
keep
speaking.
Talking, that's fine.
Okay, keep talking?
Thank you.
Okay. Okay, so 8 years ago, my daughter was just 3 months old. My then baby looked perfect and healthy to me. And so it came as a shock when newborn screening identified her as having sickle cell disease. How could this be? As it turns out, my husband was a carrier for a different disease called hemoglobin C, which is on the same chromosome as the trait for sickle cell disease. So when these 2 traits combine, they produce a phenotype that presents as sickle cell disease. And there are other hemoglobinopathies that clinically combine similarly. Who knew any of this? I mean, here I was, fully responsible for this little life. I could barely keep track of feeding schedules, tummy time, developmental milestones, diaper changes, when to offer a pacifier, when to permanently yank the pacifier. And so now I had to become an expert in this rare disease also. My Google history The search history for that year was wild. What can I say about that? We didn't have AI back then. Sometimes I feel like if I've earned an honorary medical degree in sickle cell disease, though sadly the tuition payments have all been in the form of payments to the ER parking meters in terms of fees. So in all seriousness, the first year was filled with worry and learning, and then learning and some more worry. We quickly realized that a fever or pain with a child with sickle cell disease is not a small thing. It can be a medical emergency. And so we learned how to monitor her closely, when to go to the hospital, and how to advocate for her care. So over the years, my daughter has had several hospitalizations, even more ER visits. Some of them were infections, others were pain crises. Every time it meant dropping everything, work, school, family routines, all to be at her bedside. Daily medication and treatment are now part of her normal life. My daughter does take hydroxyurea, which has helped her body to prevent infections, protect organ function, and reduce the number of vaso-occlusive pain crises that she experiences, and therefore less ER visits. But the challenges remain. She still gets sick often. A common cold can mean a trip to the ER. Is this a bruise, or that's part of normal childhood? Or is this the start of a pain crisis? For us as parents, we are in a constant state of vigilance. So managing sickle cell disease doesn't stop when she leaves the hospital. It's part of everyday life. And while we're at school or in the community and in the home, we've had to work closely with care providers, teachers, and staff to understand that what sickle cell means, that the fatigue is real, even if she looks fine, that pain can be misattributed. Long stays in the hospital can be isolating and difficult. And after a few bad local interactions at hospitals that were close to us, we started going exclusively to one hospital that had wholeheartedly adopted the quality standard. And there we found we started receiving more consistent care. And not being able to be treated effectively locally can be frustrating. There's absolutely no reason why somebody should have to drive 2 hours to access effective care. So in terms of the family impact, sickle cell disease doesn't only affect the child who has it, it affects the whole family. The reality is that plans change because my daughter's in the hospital. Extended family has had to learn how to find the warning signs and know how to respond and how to support us while we are supporting my daughter. So as parents, we live with constant mental load of asking, is she okay? Did the teachers get adequately advised? Is this pool or the swim causing a vaso-occlusive crisis? You know, what are the signs? Are we overreacting in this case, or are we acting appropriately? Will she be in the emergency room tonight because she started sniffling this afternoon? So for families like mine, sickle cell disease significantly impacts our emotional and physical and financial, presents interesting financial challenges as well, right? We have to manage complex care routines while advocating for our children's mental and medical needs. Caregiving can be demanding as it requires that emotional support and that coordination of the medical care and responding to the health crises. This responsibility can create strains in relationships and impact mental health and disrupt daily life. Costs that are associated with ongoing medical care, missed work days, long-term treatments can also be overwhelming. So sickle cell disease is invisible to most people, but it presents daily challenges in family life. It requires planning, vigilance, and resilience. And my hope in sharing this story is to give a voice to what families live with every day and to encourage continued support, awareness, and resources within the Ontario health system. I want to come out of the shadows, and I want to put a face to these challenges. It's important to clarify that I want us to move from theorizing what could be and what should be to a new reality, which would be better health access and treatment, which starts with awareness and education. A plan to combat stigma and misconceptions of what sickle cell disease is and how it affects families. Improved emergency processes and full wholehearted adoption of the quality standards. I want to globally promote options for cures and building more supportive communities. I want to invite all of you here today to participate in that dream with me so that families who have individuals affected by sickle cell disease experience health equity, empathy, support, and action. I don't want or expect, well, maybe I do want, superheroes in the systems. And if one does show up with a cape, I won't say no. What we really do also need are partners who understand that persons with sickle cell disease, not just children, deserve effective and timely medical care, but also the understanding and accommodations outside of the emergency rooms, in the schools, in the community, so that life is not just about surviving, it becomes much more about thriving. So thank you for giving me this platform and for listening.
Thank you so much, Ms. Oduwale. Well iterated, and thank you for allowing yourself to be vulnerable to share your personal journey. And thank you for also reminding us on why we are here and what we should be aspiring for. Thank you so much. I'll go to the next slide. So thank you. I think it's very important before we continue to ask our panelists that have spoken so far questions or to provide our own feedback to what they've said. So we have a few minutes that we have marked for that. And so if you would like to speak, you can raise your hand and we will call you to speak, either to ask Carol Kennedy from Ontario Health Questions or to ask Mary or Fitian based on their presentation so far. Thank you. So you can use the reaction button on the bottom of your screen to raise your hand, and we will be happy to have you speak. Thank you. While we are waiting for folks' questions, I have a question for Fitian and for Mary. And I would like to ask each of you, what do you think can also be done to advance improvement in clinicians utilizing the quality standards? Are there anything else that you think should be done to ensure that more clinicians in our hospitals are utilizing the quality standards when providing care for people with sickle cell disease? And either of you can go first. Thank you. Mary, yes, you can go first. Yes.
Sure, I can jump in. I'm not sure on how the actual training of the quality standards goes in terms of like ensuring that, it's not just, a document that is read and then maybe put away, that it serves much more like an active kind of referral guide, and one that, clinicians can, use as like a checklist while they have, a patient in front of them to ensure that, they can be self-accountable for whether or not the care they're delivering meets the quality standards, or if there's like hospital protocols that help ensure that that I guess results feedback at the earliest point to address anything that's not happening appropriately. at that first encounter, at the first level, long before, patients leave, and then, may need to use like other ways to advocate for what's gone wrong with their encounter.
Thank you. Fitzia, any comments?
I'm Lanre, I'm happy to, like, some of the things that we've been doing, like the e-report, having live, like, up-to-date data that we can share back to the regions, that can then go back to the hospitals on, because in the past, before we had the e-report, there are data lags of a period like a year or two or even more than that. But so having our e-report, we have data analytics updated every quarter. We meet every quarter with the regions, the Ontario Health regions. We've been putting together decks so we can, identify hospitals that are lower performers. We've been able, because we have so many levers for implementation, like the evidence to practice program, the community of practice, we've been able to identify, what hospitals aren't engaged in any of these, like they don't have attendance or membership on any of these programs, so that we can feed that information through the regions back to the hospitals. So hopefully some of that real-time feedback has been helpful to identify, where we can target more like which hospitals need to work more, need more education. It's, when we got the funding to do the one-time funding for implementation, we really looked at, when we went to the regions, we said, certain hospitals, this is where we'd recommend targeting some of the funding, because their wait times, there were longer. They were not performing as well as some other areas. So I think those have been really helpful levers. Jennifer, I don't know, do you have anything else to add to that?
Thanks, Carol. And I think that relates to the question that Delaney has in the chat as well, about the accountability piece. And absolutely, I think the e-report is such an important part of that. So to be able to see that data right away, to be able to compare what's happening between hospitals and across the province, to be able to keep track of some of those indicators for which sites are keeping up with the quality standard. One of the pieces that I see related to this, and in Delaney's question in the chat as well, is around measures in place to hold hospitals to account who are not keeping pace with the gold standard. And I think that there are some measures of high performance in other areas that are directly tied to funding. That's not something that is in place yet for sickle cell, but maybe that is something that could be explored in the future.
Thank you so much, Carol and Jennifer, for that. And I just also want to mention that we have been asking that the measuring metrics that hospitals are using needs to be updated. And I believe the ministry and Ontario Health have listened to that. And I know, because from some of our recent meetings, they have told us that what we're asking for is there has to be quality of care questions in the metrics, right? It's not just about how many people pass through ER and pass through admission and all of that, but people need to also be able to be held accountable for the quality of care that patients are receiving. And I know from my last meeting, I've heard that Ontario Health is working on updating and ensuring that quality questions are part of the measuring metrics for hospitals. Thank you so much for that question and for your comment. Mr. Hines, does that answer your question, or do you still want me to have Dr. Brian or Miss Kennedy to, okay, thank you. Thank you for that. Now back to Miss Fitzanne Owl to provide us if she has any other feedback on what else can be done to ensure that more clinicians are, number one, utilizing the quality standards, and as well as it's being implemented, using the same standard in every hospital. Thank you.
I think what is being physically implemented with like the backtracking and all of that is great, but I think it also plays a part in knowing what your biases are when looking at the quality standards as a clinician, as a nurse, as an ED doc, and checking those at the door. So we could sit here and like the data and the numbers and we're doing great, but it's also your biases and what do you think, what do you believe prior to all of this information coming out. I do a lot of education with Karen at like Lake Ridge hospitals, and one thing that she always mentions is when you're on the highway, you see a Ford F-150, what do you automatically think? It's a white male. That's a bias. And it's not like we inherently like forcefully think these things. They're just natural. They're just like a stereotype. It's just a stereotype. And you have to check those things at the door before you even walk in to be able to receive the information given by the quality standards. Yes, they're put in place. Yes, they could be like a checklist. Love that idea, Mary, having something on your person, having something in the area so that you know you're checking all these things off. But it's also, what are your biases? Learn to put your personal biases to the side and treat your patient as the patient in front of you. And I think that is the disconnect with the few that are left to be educated, the few clinicians, nurses, docs that are left to be educated. They won't check their biases, especially the older ones that have been doing this for years. A lot of them I find are very set in their ways and you can't tell me anything because they know or they think they know, right? So that would be my only like addition to it. So the physical data is great. The having maybe like 6-month check-ins, making sure everyone's, doing what they're supposed to, but numbers can also lie because as much as you put forth that, yeah, we're doing this amount of whatever, we've seen this many patients and this is what's going on, there's also, what are you thinking? What were your initial thoughts on sickle cell and sickle cell patients, and what did you initially think of us? Can you disconnect that part of your brain? I don't care if you want to put it down and pick it back up, but disconnect that when you're dealing with us. And I think that is hard for many people.
Thank you, Fitzanne. If I may, and Shaman, I see your hand. I'll call you shortly. If I may say, as you know, SCAGO has the e-learning models that has anti-Black racism, biases, and stigma discrimination. There's also the anti-Black racism training that Ontario Health has also been promoting. And I would say more and more clinicians are taking these programs and this training, as you will see in what as you would see in what Carol shared earlier. But my question to you would be, still on this question, with all of that that's been done, right, to ensure that more clinicians understand biases, stigma, discrimination, and that they can check their biases at home before coming to work. In addition to all of these trainings, is there anything else? Because yes, it's good, I would say it would be great for everybody to do that. What do you think can also be done to ensure that this happens for more clinicians, right? Like you mentioned, some of the older folks, right, who's been operating one way and thinking one way, it might be difficult for them. Do you have any suggestion or recommendation on what else we should be doing to ensure that more clinicians check their biases at home before coming to work? And Mary or Fitzanne, and either can.
I mean, for me, I know positive reinforcement is really great for promoting changes in general and promoting behavior we want to see. So, you know, maybe we need to have like a cheerleading website of superstar doctors who have really wholeheartedly, adopted the quality standards and are high performers for ensuring that their patients are receiving optimal care. And maybe we need to promote those people who are doing, or doing or operating their practice in such a way that they can be an example and they can share some of the things that they're doing that helps them meet their patients' needs. And so as some clinicians maybe see these highlights, can be encouraged and learn from them and maybe aspire that they can be in that spotlight, in the next term or something like that. Like maybe we need to start really highlighting the people who are doing or who have
Amazing
adopted
work.
this. Yes.
Thank you. That's very helpful. Thank you. Fitian, you have anything to add to that, or are we good?
No, I completely agree with that. That would it would most likely help shine a light on those that are working and those that need to do a little bit better, not in a negative way, but it would definitely shine a light on what's going on, especially for if it's accessible to the patients as well. We'd have an idea of like where we can go and like what works. Because I know I have friends that'll call the hospital and be like, is my doctor there? Like, is my favorite person there, before they even go to the emergency department, right? So implementing something like that would be like, okay, I can go to this hospital. I know that this one, even if I'm not in my area, I can go here because these are like highlighted and these doctors are spotlighted. So I completely agree.
Thank you. I'm going to go to those who raise their hands, if that's okay. So we have Dr. Jody Odani. If you want to go first, and then we will have Mr. Shaman Moore.
Hi, good afternoon, everybody. Thank you so much for allowing us to speak here. I wanted to give some thoughts from the perspective of a physician who sees some of these sickle cell patients in the ER when hematology is consulted. Just to echo what Marion Fitz-In have mentioned prior to this, I do think more efforts towards training physicians and other healthcare workers to sort of eliminate bias is important. But I also want to look at it from the lens of knowing that Ontario healthcare systems in general throughout the province are strained. So unfortunately, the reality is even if we improve and eliminate some of these biases, we might still run into issues where healthcare workers feel like they know what they need to do, but because of system constraints, they don't feel like they can achieve the goals that they would like to achieve. Just to give you another example, we have a lot of warning scores or certain metrics that we use in real time in a lot of these electronic medical records that allow us to see when a patient's in trouble. So that I think sometimes we need to think of ways we can improve healthcare while eliminating human error and human bias out of it, right? Make it hard for any healthcare professional to ignore, right? So for example, when a patient comes in that's really sick and they have a lot of abnormal vital signs, we have a lot of early warning scores that come up in real time in their chart to say, hey, this patient looks like they're in trouble. We need to think about ways we can use technology to our advantage. And when someone comes in with a high mental health screening score, it pops up on your chart. You can't even go into the chart without having to read that, right? So that's one suggestion of, yes, it's important to make sure more healthcare workers are trained, but we should think of ways we can use technology and other tools to our advantage to create a situation where it's like you can't ignore it because it's going to keep beeping you. Hey, it's been 20 minutes since this person got pain medication or attention. Now it's been 30, now it's been 40, now it's been 50. Make it to the point that even if it's that one person in the ER who has all the bias in the world, they cannot ignore it. So yeah, that's just what I wanted to say.
That's amazing. Thank you so much for that feedback. And now to Mr. Shaman Moore. You are mute, Mr. Moore.
Can you hear me now?
Yes.
Yes. I noticed on the list earlier that Mississauga Trillium was listed as one of the dedicated centers.
Yes.
Am I correct in that?
Yes.
Okay. So for someone like me, who's not familiar with the details of the standards, what should I expect now and moving forward upon arrival at the emergency department there, because these standards are now in place?
Thank you so much, Mr. Moore. I would pass it to Dr. Brian or Ms. Carol to respond to your question.
Carol, I can start us off.
Sure, and also Jennifer, just I think Trillium started is a new clinic, so they've started with pediatric. I don't think they're up and running with adults, so I'll just mention that, but I'll defer to Dr. Brian for sure.
Okay.
And thank you, Carol. Yeah, that's excellent context. So that table that we were seeing with the established clinics and the new clinics, actually, I wonder, Dapo, are you able to go back to that slide? Because that might be helpful to revisit. Just looking to see which one that was. Carol, if you can have here we are.
It's up
Got
right
it there?
now.
Oh, perfect. Great. Okay. So like Carol was mentioning, there were a number of different streams of funding for last year. Some went for established centers, some to newly funded centers. The centers, some of them have lifespan clinics, and so are caring for folks from pediatrics right through adult. Like Carol mentioned, the clinic funding for Trillium Health Partners is pediatric, although there's interest there, I understand, in doing more work in the adult area, but still to come. What you should be seeing, whether or not a hospital has a dedicated center, when you're going to seek care in the emergency department, what you should be finding is that the clinicians are familiar with sickle cell, that they understand that the pain with sickle cell is not something that you can see on a person's body, that you need to believe what patients are saying in terms of the experience of pain. What you should be seeing is that the time to pain medications is dropping significantly across the province. Now, in the stories that were shared, especially hearing from Fitzanne about experiencing improvements, and so more often now having high quality care in the emergency department than in years past, we know that there's still a ways to go. So the goal is that every time a person seeks care in an emergency department for a complication related to sickle cell disease, that they receive high quality care. And if it's pain, that means they get timely pain management and the start of pain medications within 30 minutes of triage. So that's the goal. That's what we want to see happen. Having said that, there are still a lot of variations across the province. There are a lot of variations even within centers. So we are working towards improvements, but knowing that there is, I think as Fitzanne put it, there's so much that we still need to do. So all of that to say, what I'm hoping is that if you or a family member seek care in the emergency department, that you will be more likely to encounter clinicians who are familiar with sickle cell and who are able to give appropriate care quickly. But recognizing that we know that that's not happening at every visit yet, and that there's still work to do to get where we need to be.
Oh, amazing. Thank you so much. I just want to also chime in and say that to Shaman's point, we know that, there's been some issues around getting quality care at some of the hospitals, including Trillium, and we work with Trillium to secure this funding from the ministry. And To be honest, my hope was that they would have both the pediatric and adult program together. But again, with limited funding, they were able to start with the pediatric program. But I think we will continue to see improved care in these hospitals. Shaman, I know that's very close to where you live. And this is why you are very concerned about that particular hospital. But to Dr. Brian's point, regardless of where you are, you should be able to get quality care. And there's one thing that Fitian mentioned about when we highlight the clinicians that are giving quality care, it would then allow families to see which doctors and which hospitals are giving the right care. I also want to caution us a little bit about that because we would rather the patient get care closer to home. That is the whole idea. I shouldn't have to go to UHN or go to Hamilton because that is where I'm going to find the right doctor. Every clinician in any of the Ontario hospitals should be able to provide the right care at the right time. But I do agree that, having a way to highlight those who are giving quality care, optimal care to families is also very important. Thank you so much all for chiming in here. We go on to the next slide. So I also want to say, just tying, all of what we've been discussing together, SCAGO has put together to help our families be able to provide their feedback, right, on the quality of care that they are experiencing. We have put together the hospital experience reporting portal. If you can go there quickly, let the folks see. So if you go on SCAGO website, you go to the resources and analgesia, resources and education, you will see the patient feedback portal. And this is the page whereby you can put your experience right there. This will allow us, so there's a form right there on that page that you can put your experience that you have in an hospital there. And you can put the name of the hospital, the name of the physician, your experience that you have. This will tie in also into what Christian was recommending, whereby we can look on those that have put in, that have completed this, and see those who are saying, this doctor has done fantastic job. This nurse was superb. And we can highlight these individuals. And when there's a doctor, a clinician, a nurse, or a social worker, whoever you see that is not optimal, we can also use that as an opportunity to meet with the hospital and help them, improve on the quality of care that they are providing. We hope that you will share this resource widely. I also put a link in the chat. You share this resource widely among your hospitals and so on and so forth, and the patient community, so people can start to utilize this resource to get their voice heard, in telling us. And this data will be shared with the ministry from time to time, so they also would know the hospitals that they are funding, what are the community people saying about the quality of care that these hospitals are providing. I just wanted to share that. Let's go back to the deck. Thank you very much. The link is in the chat. Thank you. And I think at this point, next slide, we will go into a short break. We think it's really important. We will resume. Thank you, Dapper. Next slide. So we have Dr. Jennifer Bryan, who will be speaking on the provincial model of care. As we have heard, it looks like it depends sometimes on. I'm sorry, can everybody kindly mute, please? Can you mute yourself? Thank you. Thank you very much. Thank you very much. Just to say, we are on the second half of the town hall, whereby Dr. Jennifer Bryan will be providing us with rationale, background, and purpose as per the provincial model of care. We have heard earlier that sometimes it depends on who you see when you show up for care in the hospital, that determine the quality of care that you still receive. And I think it's very important to have a standardized model And I think that is something that Ontario Health has been working on. And so Dr. Brian will provide us with the rationale, the background, the purpose, and also some of the need assessment results and key learnings from some of these sessions that we've heard in line with the provincial model of care. And on this note, I will pass it to Dr. Brian.
Fantastic. Thank you so much, Lanre. I'm humbled to be following some of the earlier speakers today. So lots of good learning all around. Like Lanre mentioned, I'm going to be speaking with you about an idea for a provincial model of care. So we've heard about some of the things that are going well, some of the challenges also. One of the challenges that we haven't discussed are challenges on the side of the clinicians, in particular, the need for mentorship and support for clinicians as they're working to improve care for people living with sickle cell disease. This is a quote from one of the leaders of one of the very established dedicated sickle cell centers. They found over the past year that the volume of requests that they were receiving from colleagues in other areas of the province were overwhelming. So as much as they wanted to support new centers and to support ongoing capacity building for clinicians across the province, they were feeling overwhelmed. And this is something that I heard again and again in my role as clinical lead for sickle cell with Ontario Health. Next slide, please. Hearing about some of the ongoing gaps in care, as well as some of the struggles of clinicians across the province, led to this revisiting of the idea for a provincial model of care. This is not a new idea. For those of you familiar with the 2017 Clinical Handbook on Vaso-Occlusive Crises, this was an idea that was raised there as well. And so what we've been doing since the spring is really taking steps to bring this into play. 5 key steps that we identified, starting off, of course, with speaking with key partners. We wanted to understand what the main concerns were so that they were addressed properly. We conducted a needs assessment survey in June that I'm going to speak with you a little bit about. We facilitated a series of group discussions about what a provincial model of care could or should look like. And we're at step 4 right now, where we're collaboratively developing a draft framework for how to connect centers across regions and across the province with an eye to creating a model of care that can continue to help us organize care across the province. Let's go to the next slide, please. So a little bit on the needs assessment that was done in June. We had 120 respondents from 45 different organizations. These included lived experience advisors, representatives from community organizations, administrators, and clinicians from a variety of settings. Next slide. What we asked in this needs assessment was about what were the existing connections between care sites, what was working well, what was not working well yet, and what a provincial model of care should include. So on the next slide, you can see some of the things that are working well. So renewed focus and investment. So the addition of new sources of funding over the past couple of years, we're hearing and seeing some of the impact of that. The importance of the quality standard and having metrics in order to track performance. The dedicated interprofessional sickle cell disease centers are very valued by people across the province. Available tools like those discussed by Carol earlier on, including evidence to practice, Effective early identification, allowing early intervention. So we haven't really talked so much about the neonatal screening. Mary did mention that when she was speaking earlier. And as a reminder, the neonatal screening we've had since 2006 in Ontario, and this has been incredibly helpful to be able to provide early interventions and advice for patients and families. And then finally, but certainly not least, what is working well includes engagement and collaboration with community organizations like SCAGO, like having town halls like today. Next slide, we talk about some of the areas for further improvement. And I think a big one that really leads to many of the other areas for improvement is the fragmented and disjointed care. So it can be very uncertain both for patients, families, and clinicians about how to connect with care across the province. So what are the best ways of reaching high quality care? Especially when you're living outside of major centers in Ontario. There was certainly, because of this, some duplication, underuse of expertise. We continue to see inconsistent application of the equality standard and uneven access, inefficient use of distribution of resources, limited access to critical services, including very important supports related to psychosocial and mental health, as well as the need for clarity around financial supports, particularly for folks that are not covered through OHIP. There has been limited integration with social and community supports, persistent inequities, and systemic racism, like we were hearing about earlier. Geographic barriers to care. So, hearing Mr. Moore ask about, well, if I'm closer to Trillium Health Partners, can I get high quality care there? What happens when you live further away from some of the more established dedicated centers? And ongoing education gaps among clinicians. So we see that that is changing. Carol presented some of the numbers about the folks that are getting trained. And so we'll know more about sickle cell when you're seeing them for care, but there are still gaps that remain. On the next slide, a bit of a summary about current care pathways. So we have some select sites that are acting as care hubs, either formally or informally. So Sick Kids, for example, is connected to a number of different smaller sites, providing clinical expertise and support so that folks can get high quality care closer to home. London is providing similar support to the new clinic at Windsor. Hamilton is providing support for other centers in their area, as are CHEO and Ottawa. There are also growing connections with primary care. We didn't talk so much about that yet today, but primary care, it's important, and people with sickle cell disease deserve to have a strong primary care relationship. What we were seeing with these current care pathways is that there's a real zigzagging between regions across Ontario and across the province, with most of the connections between centers being informal and depending on relationships between individual clinicians, which is a risky way to build a system because clinicians can change roles, they can change sites. We need a more consistent way of ensuring high quality care. So the next slide, the goal of the provincial model is to make this dream possible. What if you could have excellent, well-connected, high-quality care that you trusted closer to home? And that's really what we are working towards. On the next slide, some key features of a proposed provincial model. This is a bit of a sneak peek. So we have an advisory committee made up of representatives of key partners across the province that is currently reviewing the very first draft of the provincial model. They are going to have a ton of ideas, a ton of feedback to give us on this first draft that we're going to be incorporating in the coming weeks. The next draft, so after the advisory council has had their first look at this, we are going to be sharing the draft model widely. And we want to hear from each of you. What are the things in the draft model that we are getting right? What are the things that we're missing? What are the important changes that need to be made in order to make sure that we're on a path for you to be able to access high quality care close to home? Some of the key features that we have in the draft model now is a clear mechanism for collaboration between sites. So a relationship between the larger sites, the smaller sites, some criteria for different types of sites. So if you are going to be a large dedicated center for sickle cell disease, here is the list of things that you should be able to provide and the resources that you should have. We want there to be a standardized approach to comprehensive care plan that can be widely shared so that no matter where you seek care, it's very clear what your care plan is. There needs to be a mechanism for capacity building so that clinicians are continuing to grow their expertise so that when you are seeking care, you are across the desk or a table from a clinician who knows about sickle cell disease and can provide you high quality care and has also had the opportunity to address some of the issues around stigma and anti-Black racism that we heard about earlier. There needs to be ongoing engagement, of course, with community organizations like SCAGO, and we need data-driven metrics. So what are the things that we can measure that will show us whether the model is working well or not, whether care is improving across the province or not? One of the key pieces to the model is around autonomy. So while we, through the model, want to suggest a pathway to care that will involve shared care between some of the larger centers and smaller centers, we want to make sure that everyone seeking care has the right to seek care where they feel most comfortable. So while we're working on building excellent centers close to home for everybody across Ontario, if you feel more comfortable traveling the 2 hours because you've built up trust, because you've built up a relationship with a center that might be a little bit further away, we don't want to take that option away from you. So we want to maintain autonomy. If we go to the next slide, just to summarize some next steps. So that draft model, like I mentioned, is being shared right now with advisory committee members. Many of you or some of you who are participating in this session today are part of that advisory committee and will have received a message inviting you to do that first review. We're going to be sharing the draft model widely in the coming weeks. So if you are a part of the community of practice, you'll get a message that way. Otherwise, you can hear about it either on, again, on the community of practice site. And I shared a link to that when Carol was speaking earlier in the chat. We're also going to be sharing this, of course, with SCAGO to disseminate widely. Our plan is to have the first iteration of the provincial model of care ready to present in March at the Community of Practice webinar that's going to be held then. And so this will be an opportunity for everybody to see the draft and the feedback that's been received over the coming months for the model of care. This is an email address. If you have additional additional feedback or ideas as we continue to build this provincial model of care, please don't hesitate to email us. We want as many ideas and as many voices contributing to this model as possible to ensure that that people are able to get high quality care close to home in a way that they feel comfortable and with clinicians that they can trust. So I'm going to wrap up there. We'll move on next to a discussion. So we've got some time for any questions. And Lanre, I believe the questions can be to me, they can be to Carol, they can be to Mary, they can be to Fitz-Anne. And please do put your questions in the chat, or if you feel comfortable, raise up your hand and let us know so we can call on you. Thank you so much.
Thank you so much, Dr. Brian. I believe the community, we have questions around the provincial model of care. If you have any questions for Dr. Brian or for any of our previous speakers, as Dr. Brian alluded to, please, this is the time. We have a few minutes now to address those questions around the provincial model of care or any of the prior discussions we've had today. So the floor is open. I'll look for people raising their hands, or if you want to put, if you prefer to put comments in the chat, we can also do that. I don't want to put anyone into, I don't want to put anybody in a spot, but I really want people to be engaged and speak about this provincial model of care. And I'm going to actually be calling on people for their feedback if I didn't know to raise their hand. So the first person I'm going to put in the spot, unfortunately, would be Dr. Odami. Is there any feedback you have regarding the PMOC that Dr. Brian has just spoken about? You're mute.
Yeah, I guess I will say I can definitely tell that we are making strides in the right direction. But just reflecting on everything that's been said, there's still a lot of work to be done. And I think the major question I have, and I think a lot of healthcare workers have, is even if you make small improvements in different places, how do you ensure that the standard of care is adequate across the board, right? Because the unfortunate reality is, let's say we get to an excellent metric that, 50, 60, 70% of centers have met the standard. It's heartbreaking to know that the outcomes of a sickle cell patient that presents to a healthcare system becomes luck of the draw, right? We don't want a situation where the only reason someone had poor outcomes, I know a lot of the time there's more than one reason, but to know that it's just the fact that this is where they lived and this is where their hospital was and that hospital hadn't met that metric is heartbreaking, right? And I think it's achievable because the fact of the matter is, if you think of other health conditions that affect many people in a province or many people in a certain place, think of the metrics that are in place for when a patient comes in with a heart attack, right? Every hospital, whether local or big, knows this person needs aspirin at this time and they need to get these tests by this time. So it is doable when enough effort is put into the goal and people care. So yeah, I think it will take some time, but I think we now have a lot of people in our corner who have recognized that this is an issue, due in part to the amazing work SCAGO has done to raise awareness. And yeah, we'll keep working.
Thank you for that feedback. I also would like us to hear from Natalie. Natalie, sorry, I'm putting in the spot. Natalie works with the pain clinic in Ottawa. From all that's been discussed today, would you have any feedback for Ontario Health and for SCAGO on how we can do things better or around the provincial model of care and so on? Natalie.
Hello, and thank you. Can you hear me?
Yes.
Okay, terrific. No, it's difficult for me to have feedback when I don't quite know how things are going in the in the department that I'm working in. So the pain clinic is a bit maybe separate, or my role within the clinic is very separate from TOH emergency. So what it has made me consider is that we really need to be working more closely with the emergency department in order to put into context what the town hall has presented today, including the patient experience. So that's all. I always remain hopeful that the delivery of care to people living with sickle cell and their families is optimal, and that, I do see, since the 4 years that I've been in the pain clinic, a change. And so that's something that is positive for me. When I joined the pain clinic 4 years ago, we were not where we are today. So change is small, but it's happening. So that's all. Thank you.
Thank you, Natalie. If there's anyone else that'd like to make a comment, we will give you that opportunity now. Thank you. Shaman, go for it.
So, yeah, maybe I'll add a follow-up to my first question. Again, if a patient is in emerge, and they're, whether it's in a dedicated center or not, and in sickle cell crisis, and they recognize that they're not getting the care they should be getting, is there anything they or their advocate should know or can say or do to signal to the staff that they know that they should be getting better care and maybe could get better care? Anything that could maybe shift the dynamics or the narrative without offending anyone, right? Or do you just have to lay there and take it?
I have comment. I have feedback on that, but I'm wondering if maybe Carol or Jennifer wants to go first. From the basis of the quality standards, what would you recommend in that situation?
Thank you so much for that, Mr. Moore. I think it is incredibly difficult to advocate when you're in the hospital and when you're in pain. And it should go without saying, but you should not have to be doing that, right? Your only focus should be on feeling better, not having to convince the clinicians that are caring for you that you need care. But I understand that
That's often the case.
that's often the reality, right?
Yeah.
Yeah. What my suggestions, when I've gotten similar questions in the past, if this is a hospital that has been your go-to hospital and would be your go-to hospital in future if you experience a complication related to sickle cell, exploring opportunities when you're not in the emergency department, it can sometimes be helpful. I know that there's risk there. Sometimes folks are concerned about any repercussions if they make waves and speak with patient affairs, that sort of thing. If that is a route that you would be comfortable with, sometimes starting those conversations outside of the emergency department, it can lead to some impact. I am hoping that Lanre is going to talk a bit about some of the supports that are available through SCAGO for advocacy, some new opportunities in the past year that might be interesting and helpful. The other things in terms of any opportunities in the moment, I never think it's a bad idea to mention to the clinicians that are caring for you, hey, have you heard that there's an Ontario a quality standard? There are still quite a few folks that don't know that this even exists out there as a resource. Um, you know, I think that it can be it's difficult, certainly when you're in the moment, to take on that advocacy role for yourself, and to not know how it's going to be met by the clinician that's in front of you. Is this somebody who just doesn't know that the quality standard exists and doesn't know about how to provide high quality care, and when provided the information would do a better job? Or is this someone who's going to dig their heels in and not be receptive to someone who has expertise in their own disease, who's right in front of them? And I feel for you, because that's not a situation that you should be in. But I think that mentioning that there is a quality standard, it could be an opportunity for learning for the clinician that you're working with, and potentially giving them a route to provide higher quality care. The patient experience site that Lanre mentioned earlier, I think is really exciting through SCAGO as an opportunity to provide feedback when things either went well or when they didn't go well. Lanre and SCAGO have been doing such a great job in meeting with hospitals and giving feedback to say, hey, look, these are the things that are going well, these are the things that are not going well. And in situations where you might not feel that you have the power to be able to do that kind of advocacy yourself in the moment, or may not feel comfortable if you're concerned about repercussions from making a concern or complaint known, that is another route that's available to you. But I'm going to stop talking and turn things back over to Lanre, because there are some really important resources through SCAGO that you need to know about.
Thank you so much, Jennifer. I see that Mary had her hand raised. I'll let Mary speak, and then I will talk after. Mary?
Certainly. Just really briefly, as a pediatric patient, what I found helpful in terms of not having to, use my own voice to, advocate for my daughter, is I'd had the hematologist write a care letter, and it diagrammed kind of what the overview of care needs to be upon encountering an ER visit. And so, it kind of talked about the routine screenings that needed to happen when, pain medicine should be administered for. And this was all before the quality standard had come into place. So now what I would hope is that it would maybe summarize some of the things that are in the quality standard and point to the quality standard. And I had like 20 of these letters, one in my wallet, one in the car, 3 in the bag that I would take when we'd go to the ER with the child. And, I would hand that, to the triage nurse and say, here are our symptoms, here's why we're here, and here is a letter from the hematologist. And if you have any questions about, the care that's described in this letter, please contact them. And so it pushed, our clinic at Sick Kids as the main contact. And they did actually reach out and have conversations and made decisions together as to how to adhere to the care plan or how to deviate from it. And so I thought that that was helpful, so that I didn't have to be the one. Like I said, I'm not a medical provider. I don't know the details. I wouldn't necessarily be able to express myself and relieve the burden of that advocacy and put, the long-term care provider in an opportunity for them to work together. So I felt that worked well for me back then.
Thank you, Mary. If I may just also add, we know that some hospitals have developed individual care plan, right, for patients. So, that way, when a patient shows up, they can look at the care plan and they can, use that to ensure that the patient gets the right care. But we still know that sometimes that's still not the case. Patients are still not getting the right care. And sometimes when you are in crisis, it's difficult to advocate for yourself. We see this all the time. And when you don't have a family member with you that can help you advocate for yourself, then it becomes very difficult when you are not getting the right care at that right spot. So I'm listening and I heard you, Shaman. And as they say, necessity is the mother of invention, right? And I think from us hearing from families about, I was in the hospital, I couldn't speak for myself and I didn't get the right care, or they're calling or they're saying, I've been here in pain 6 hours, 5 hours, not getting my payment. That was why we established the patient well-being coordinator program. And therefore, if I can quickly share my screen, so I can show what that card look like. The patient well-being coordinator card is something that we have given to hospitals, right, who are working with us. And I think patients should also have it. This is for GTA. So we have this role in London and Windsor and GTA. We are currently recruiting for the role in Ottawa, in Thunder Bay, and some other places, because it's very important, like to be able to say, who do I call to help me and advocate that I get the right care, right? And this role is not 9 to 5, because we understand that some crisis does not tell you I'm only gonna come at 9 a.m. in the morning, or I'm gonna come before 5 p.m. before the social worker in the hospital goes home. We want to make sure that you have access to somebody who can be with you, stand with you to ensure that you have that right care. As we continue to see improvement, due to all of the great work that Ontario Health is doing, it's important that there's always somebody who can support. And so this card should be in most of the hospitals. Their ER, inpatient, anywhere that a sickle cell patient will interact within the hospital system, they should have the card. So I'm sharing this as a sample of how the card, looks like. And this person can support virtually or can be in person, depending on what is necessary. So that's one. And then, like Dr. Bryan said, right, if you're able to also, it might not be when you are in the hospital, but that would be an opportunity for you to also be able to report to patient relations in the hospital if you did not feel like you received the right care. Even if you received the right care, it's also good to let them know I was on admission, or I was in ER, and the care I received was excellent. When we talk to patient relations in many hospitals about the gap, they said, we don't think sickle cell patients have any problems in our hospital. And when we say, no, they do, and then they respond, we don't have any reports, we don't have any statistics. Nobody is reporting. We understand it might be because of backlash, but I want to say to you, there is not going to be any backlash if you are reporting. We are standing with you to ensure that when you report, it's only to help improve the quality of care that patients are receiving. Patients who have made this kind of report, we have supported them, work with them, and sat with them in meetings with patient relations. And sometimes they have to call that physician or that nurse also into those meetings. And that has helped also with educating those clinicians to ensure that next time they get the right care. So I want to say, let's get our voice heard. Let's not be afraid. We are here with you to ensure that you continue to get the quality care. And with the portal that we just created, that also gives you an additional voice to say, okay, here is the kind of care that I receive. And we're not going to share your information, your name or anything with any third party, no hospital, nothing. But we're going to use those to help us ensure that, the hospitals continue to deliver. And with you, Sherman, and with our families, right, we will continue to ensure that, quality care is provided in Ontario. for our families. I wanted to say kudos also to Ontario Health, because Ontario Health is pushing, is trying. They are listening. We asked them to fund new centers. They did. We asked them to fund assistance centers. They did. Now, as families, as people that are affected, we have to help them understand where there's huge impact and where there's no impact, so they can understand where the money that they're spending is going and how that money is improving, the quality of care in Ontario. I'm going to stop sharing this and we're going to go back to the slide, but I thought it's very important that I mention that. Did that kind of answer your question, Sherman?
Yes, it does. Sort of. I would actually like to make a comment.
Sure.
I would like to thank you, Lenry, and everyone else involved in this effort, because as you know, we've been involved in it for a long time. I don't know if you recall the meeting you and I had with the education team at Mississauga Trillium back almost 10 years ago after an incident there. And we spoke at the Ontario legislature way back in 2011 when Mike Cole introduced the initial bill about this. So it's been worked on for a number of years by a lot of people, and I do see progress. And I'm thankful for that and grateful that the younger people with sickle cell coming up will have this to look forward to. Having said that, though, I recognize that for us, people in our age group, we've I guess sort of won the lottery already, arriving at elderly status with sickle cell, and so perhaps there is not as much available for us today or coming in the very near future. I accept that. So I would just say to you guys, keep at it, keep up the fight. You've done a great job so far, and I expect you will continue to do the same moving forward. And I thank you.
Thank you, Sherman. And I think the fight continues. And, a luta, as they say, a luta continua. And so thank you for all you've done over the years. Honestly, as an older person with sickle cell in your 70s now, you've shared with me, you and your siblings have shared with me how in the 60s there was nothing. So there's so much progress that we have made, and we will continue to ensure that additional progress is being made. Before we close, we have a short survey for you. If you can quickly, please complete the survey in 2 minutes. Thank you. While we are doing the survey, I wanted to look at the comments in the chat. Dr. Brian, thank you for advising that at your center at UHN, if a patient raises a concern with patient relations, this automatically raises concern to the department head, and then it makes it possible to make department level changes, including education and care pathway, which is amazing. And Dr. Newton also advised that if you're in the hospital, you can also reach out for the request for social worker, right, in the unit, and that has been helpful in bridging communication gaps as well and ensuring that maybe patients will get improved quality care. There is a very disturbing message. I'm so sorry, Khadija, for your experience. Khadija advised that on August 31st, she was hospitalized and received hydromorphine injection. And then due to the medication side effects, she was at risk of falling. And despite this, she attempted to use the washroom alone and she nearly fell. And then she also mistakenly used the disposable bowl meant for vomiting to urinate. And the female nurse reaction was very upsetting. She appeared very angry, spoke rudely to her. And later, even a short walk from the emergency department to the taxi worsened her condition, causing breathing difficulties and vomiting when she arrived home. We're very sorry that you had to get this treatment. And it has TGH, Dr. Brian. I'm not sure if you want to maybe, we can address this offline with Khadija and to ensure that, even when patients make errors, right? There still be empathy and compassion in how we react and deal with them. Thank you for sharing that. And Dr. Sandra Newton is asking if the quality standards are readily available for reference on internal clinic and inpatient units and hospitals for the healthcare team's immediate reference. And then if not, could we make this possible more easily accessible? Dr. Brian,
I can take that question.
Sure. Sure.
Early in development of the quality standards, we did produce printed quality standards, and we did move away from printed, and they are currently only available online. So they can be viewed on a phone or on a computer, but there are PDFs that could be printed. So at a hospital, a request could be made to print the patient guide and have them sitting out for patients to pick up. But we don't have them professionally printed in booklets. But I will take that feedback back to our program. It's not, we do hear occasionally from people that still want to see them printed.
And I thank you so much for that. And I also want to mention that that's also part of what the patient wellbeing coordinator will have available. That if a patient is not receiving the right care, they can also ensure and point the clinician to make sure that they do have access to that. Because of time, we are over our time. We will have to unfortunately close today's session. So in closing, I wanted to iterate some of the takeaways. Like number one, we need to look at utilizing technology. So this is Dr. Odami's comment, utilizing technology to ensure clinicians treating patients within the hospital system are unable to ignore warnings and alerts on patient charts to ensure that patients get the right care at the right time. We also have to utilize the power of positive reinforcement. That was a comment from Miri. How do we recognize those who are providing optimal care to ensure that those who may need more support can then aspire to get there as well, so they can also be recognized. We hope some of the things that SCAGO is doing would lead us there, and I'm also happy that some hospitals are doing that. I know Dr. Brian said there is something similar that they're already doing at UHN. I also saw a comment that London Health has something so that whereby patients can also identify clinicians who are doing well, and they can be recognized within the hospital system. That's excellent. We also heard about the provincial model of care, and I think more next steps on that would be shared widely by Ontario Health, also by SCAGO. If you are on our newsletter, you will be getting more information on this shortly. So be on the lookout, and we encourage you to also share it widely among your own, colleagues and so on. As we showed you, now there is a patient hospital experience reporting portal. Let's help get the data so we can truly say hospitals are providing quality care, or there are still areas whereby they need to be improving. Your feedback is very, very important. We also learned that today's session has also helped to ensure that more departments and more clinicians are working more closely together. And so we want to thank you again for giving us your time. And there will be a recording of today's session, which will be shared by newsletter as well. And to all of those who registered, you can review again and you can share widely to ensure that you are able to continue to help advance improve health outcomes for people with sickle cell in Hart Province. Thank you again, everyone, for your time, and we look forward to continue to engage with you. Thank you.